I feel privileged to speak before you today on the 25th anniversary of the founding of NIAMS. And what I'm going to talk about today is really progress that's been done in many, many labs, including my own. But importantly, what I'm going to tell you is only a small fraction of the advances and discoveries in lupus made possible by NIAMS. I'm grateful that Steve invited me. I appreciate Susanna's introduction. And most importantly, I appreciate their tolerating my tenacity or stubbornness, which Susanna alluded to. Lupus is a prototype systemic autoimmune disease characterized by an immune response broadly directed against the self. And it manifests in skin disease, joint disease, mucosal disease, renal disease, and brain disease. We don't really know what causes lupus, but the clinical manifestations of autoimmunity are tissue injury. What's become clear in the recent past is that there's a genetic susceptibility to lupus. In fact, work that's been supported by NIAMS now indicates that there are at least 40 risk factor genes. These risk factor genes provide susceptibility to the host, but they're environmental triggers, and those environmental triggers are perhaps viruses, perhaps endogenous or exogenous nucleic acids, but in the susceptible host with the environmental trigger, you begin to have autoimmunity. And what's remarkable is that the autoimmunity accelerates tissue damage, and the tissue damage releases more nucleic acids, which then leads to a process that we have to abate. And by understanding the mechanism of disease, we can abate the process. And the process of tissue injury manifests in patients with inflammation in kidneys, central nervous system, skin, blood, and joints. But what I'm going to tell you about, I think this is a different presentation. I'm going to skip this slide. What I'm going to tell you about is research in my laboratory that deals with pregnancy complications, because lupus presents in women predominantly and generally in their reproductive years. And they develop hypertension, placental insufficiency, which manifests in growth restriction and sometimes fetal loss, and a disease called preeclampsia, which I'll tell you more about. And preeclampsia threatens the life of both the mothers and the babies. But importantly, you heard a little bit about autoantibodies in the skin. Importantly, the presence of antiphospholipid antibodies, which I'll term APLs, is the strongest predictor of pregnancy loss and other complications in lupus. So to understand what happens in patients who develop lupus, we developed a mouse model. We injected pregnant mice. A mouse pregnancy lasts about 21 days. We injected pregnant mice with immunoglobulin containing antiphospholipid antibodies from patients with lupus or those from healthy individuals during pregnancy, and sacrificed mice at 15 days, which is about the second trimester. And using this model, we were able to recapitulate human disease in mice. Passive transfer of antiphospholipid antibodies into the pregnant mice caused fetal loss and growth restriction. So on the top, this is the uterus of a mouse treated with IgG from a healthy individual, and each of these is a developing pup. Here's the eye, and this is the back. And these two uteri are from mice treated with antiphospholipid antibodies, and the arrows point to resorption sites. These are fetuses that died in utero, and what would have been surviving pups are smaller than those on the top. So we recapitulated exactly what we see in the patients. But using this model then, how can we understand the mechanism of disease? Well, we know the antiphospholipid antibodies deposit on the placental surface, and this is the wrong presentation. I'm sorry. I changed it and took out slides, and I reloaded it. So tell me what you want me to do. I can go forward. But there are some changes in it. So the question we asked was, is it inflammation or thrombosis, and what are the mediators and mechanisms of damage, and how can we use that to develop new therapies? So by using very focused inhibitors and mice deficient in different proteins that cause inflammation, we could develop an understanding of the mediators and mechanisms. And what we discovered, actually unexpectedly, was that the complement cascade is critical to mediating damage. So I'll tell you a bit about complement. There are 30 proteins, some of which are cell-bound and some on the circulation. And the main role of complement in humans is to protect them from infection. Complement activation leads to the killing of bugs. But when there's inappropriate, aberrant complement activation, host tissue can be damaged. And what we can see here is that in mice treated with antiphospholipid antibodies that receive CRYIG, which is an inhibitor of complement, we rescue all the fetal resorptions. So this argued that in the presence of complement inhibitors, we're able to rescue pregnancy, so complement plays a critical role in damage. Here, this graph shows you more precisely that antiphospholipid antibodies result in a 20% frequency of fetal resorption. Complement inhibitors rescue that phenotype, and that the fetuses in the mice treated with antiphospholipid antibodies who would have survived are 50% smaller, and again, inhibiting complement rescues phenotype. But in addition to the risk to the fetus, patients with lupus and antiphospholipid antibodies who are pregnant are at risk themselves. And they're at risk for an entity called preeclampsia. It's a pregnancy-specific disease characterized by hypertension, high blood pressure, and proteinuria, which is a manifestation of renal injury, and it occurs generally after about 20 weeks. This is a very important public health problem, more broadly than affecting lupus patients, and is a critical cause of morbidity and mortality of both women and fetuses in the United States, and is more common in patients with lupus, but importantly, there's no treatment for it. And the only cure is delivery, even if that means delivering very early a baby that may weigh less than 1 pound. So preeclampsia occurs when the placenta isn't vascularized properly by the maternal arteries. So here's an unmodified maternal artery. This is an artery that's narrow. It's high pressure and low volume flow. It doesn't nourish the placenta well. It doesn't nourish the fetus well, and this is a normal artery. In preeclampsia, this occurs, but the question really arises is how does it happen and how can it be prevented? So we were able to use our mouse model again to address this question. What we found was that these antiphospholipid antibodies that we know deposit in mouse placenta as well as human placenta can activate complement. And complement activation leads to the production of anti-angiogenic factors. These are factors that decrease the ability of the arteries to remodel adequately and lead to preeclampsia in the mice. So here we put together the antiphospholipid antibody, the complement as a mediator, and the presence of these anti-angiogenic factors, which are quite important in the phenotype of preeclampsia. So what are the implications for treatment to patients? And how can we predict risk? Because if we talk about implications for treatment, we have to treat patients at risk and identify risk. So here, I'm very grateful to NIAMS for giving us the opportunity to translate the mouse studies which they funded into patients. And that's the PROMISSE study, where we were specifically looking to identify evidence of activated complement proteins in lupus patients destined to poor pregnancy outcomes. PROMISSE is a prospective observational study where we identify markers that predict poor outcome in lupus patients and APL patients. And you can see that it's a 9-center study. We enroll patients with lupus, with antiphospholipid antibodies, with both. And we've done very well in terms of our recruitment up to date. So I'll tell you a few short stories that we've learned from the PROMISSE study. From this complex table, I'd like to make 3 points. First, that patients with lupus and antiphospholipid antibodies indeed do have poor pregnancy outcomes. Oops, 1 second. They're at risk for neonatal death. That's death related to complications of prematurity, fetal deaths, which are miscarriage and stillbirths, growth restriction, and preterm delivery. They're at risk for preeclampsia, as I talked about before, and in fact our prospective study supports it. But importantly, if you look across this line, the patients with lupus alone, as opposed to those with lupus and antiphospholipid antibodies, do a lot better than we had predicted from old literature. And I think that relates to our improved treatment. But what are the specific discoveries from PROMISSE thus far that have implications for patients? And even though we're not finished enrolling, I think we really have made important progress. First, lupus flares are extremely infrequent in patients who are clinically stable at conception. And pregnancies are uncomplicated in these patients. So why is it important to know, and how has it changed care? What we've learned from this is that we can counsel patients that it's important to wait till their lupus is stable before embarking upon pregnancy, and we can tell them at that point that their outcomes are likely to be good. And in years past, patients with lupus were counseled not to get pregnant because of the risk to them and to their fetuses or offspring. We've also discovered that lupus anticoagulant, which is a particular kind of antiphospholipid antibody, is the most powerful predictor of poor outcomes in antiphospholipid positive patients. So how does that change care and impact on what we tell patients? It allows us to intensely monitor and have a low threshold to intervene in patients with high titer, with the presence of lupus anticoagulant antibodies, but it also permits us to avoid aggressive and potentially dangerous treatments in patients who don't have lupus anticoagulants. And that's a very big change. We've discovered a blood test that may identify patients at high risk for preeclampsia. So circulating anti-angiogenic factors, those factors that can be produced by complement-activated leukocytes, predict preeclampsia in patients with lupus and antiphospholipid antibodies. And then we've learned that activation of complement early in pregnancy can be detected in the blood of women destined to have preeclampsia. And these are women who can benefit the most from newly developed drugs that target the complement cascade. These are drugs that have been approved for other diseases, so they're available already. And these patients with elevated levels of complement activation in the activation products in their blood may be the logical group to do these clinical trials in. And finally, we've discovered mutations in complement pathway genes that lead to uncontrolled complement activation. And these are associated with preeclampsia in patients with lupus and antiphospholipid antibodies. And these are the first genetic risk factors identified for preeclampsia in lupus patients. And I think what really is impactful is that we studied non-autoimmune preeclamptic patients and found mutations in the same pathway. So here we have a relatively uncommon disease, a fortunately relatively uncommon manifestation of disease that can be very important for a public health problem like preeclampsia, which occurs in up to 4% of the population at their first pregnancy. So without, and this discovery of the complement regulatory mutations in patients with preeclampsia validates the importance of using animal models to study human disease. Without our findings in mice, we or no one else would have considered complement as a mediator of pregnancy complications in lupus patients. This was entirely unconventional, and it was really the confidence that NIAMS had in really taking a risk and allowing us to test a hypothesis in patients that we found in a compelling way in mice. So these are the slides I removed. So while we expect to learn a lot more from the PROMISSE cohort, my hope is that our next step will be an interventional study in the patients at the highest risk. Our goal is to identify those through PROMISSE, and the ability to have a prospective interventional trial will really directly let us translate our discoveries in mice and in biomarkers to improve the health of mothers with lupus and their children. First, I've got to thank all the patients in PROMISSE who agreed to participate. We've had over 600 patients at 9 centers. They're followed every month. They come see us every month, and we draw blood and ask them a lot of questions. As Susanna said, I build collaborations, so you can see they're investigators from all over North America. They're European geneticists who did some of the sequencing, and I've had collaborators from many places to help with the mouse studies. but I want to highlight the importance of clinical coordinators in doing this kind of human research. And then, again, thank NIAMS, the Office of Research in Women's Health, the Mary Kirkland Center at HSS, and the Alliance for Lupus Research. Thank you.